Hello everybody, my name is David Crook. Welcome back. Today we're going to be discussing ocular ultrasound. So the objectives today is to look at the indications, why we do this ultrasound, a little bit about technique, how we do it, and then pathology, looking at the different things that we can see on our ocular ultrasound. So indications for why we're doing it. Usually we're looking at people with some kind of vision loss, usually painless, painful, less useful, but can see some things, but usually painless. Floaters, flashing lights, they come in, they say, yeah, I'm seeing some weird stuff in my vision. And then ocular trauma, looking at a couple different things. So things that we will look at today are retinal detachment, vitreous detachment, vitreal hemorrhage, and then lens dislocation. So here's a picture of the basic positioning and what probe we're using. So we usually have them in a supine, lying flat position. We have them closing their eyes. We put plenty of eye gel. You can't put too much. Just put on a ton and then use that linear probe. And that's the best probe to use. You can use a tegaderm and put it over their eye to protect their eye, but you're really not protecting their eye from much. It's just jelly. You can wash it off afterwards with a rag or something. And it can, when you take that tegaderm off, can pull at their eyelids, their hairs, things like that can be a little painful for them. So this is the basic ultrasound image that you're going to see. We have at the very topmost portion, you're going to see the cornea first, which makes sense. You have the cornea, the anterior compartment or vitreal compartment. And then you have the iris here with the pupil, followed by the lens just deep to that. You have the posterior vitreal cavity, followed by the retina. And then this dark shadow cast behind it. It looks like a shadow, but it's the optic nerve. It's this dark hypoechoic structure. So first, we're going to just take a look at a normal ocular ultrasound. So here we have the patients. It's not quite in the middle of the screen, but looking back and forth. We see the iris. We see the cornea at the very top. We see the iris, that shimmering hyperechoic disc seen right about there. Boom. And then finally the retina, and then that shadow right there, boom, is the optic nerve. You're going to see it attaching to the retina. It moves around with the movement of the eye. So here's a beautiful drawing that I made on paint of the first pathology that we're going to look at, which is retinal detachment. So in this, we're going to see a serpentine or serpentiginous structure in the posterior cavity of the eye. It's linear curving structure that's attached to the optic nerve. That's the big thing, is that it's attached to the optic nerve. Look at two ocular ultrasounds where, once again, we see this abnormal serpentine linear structure that we don't see it here attaching to the optic nerve, but in the next one we will. You can have some schmutz, some heterogeneous crystals and stuff like that. That's can absolutely be associated with it. And then here we're going to see one where there's the optic nerve, and you can see just the retinal detachment starting from it. It's not going beyond it. It's starting right at that optic nerve, so it's attached to it. It's a retinal detachment, not a posterior vitreal detachment, which we're going to talk about shortly. So here is a drawing of a posterior vitreal detachment where you have not the retina, but the vitreous detaching from the posterior wall of the eye. Usually people are coming in with floaters, flashing lights. If this happens, less vision loss. So here's a still image. You can absolutely have some hemorrhage behind it, so some more heterogeneous kind of gray material behind the vitreous as it's detached. And then the big thing, once again, is that it's not attached to the optic nerve. It stays right there. It's not attached to the optic nerve. You can also just have vitreal hemorrhage where there's no detachment and you just have some hyperechoic to just barely hyperechoic substance in the vitreal cavity. You would have what's called a washing machine sign where it just moves a lot with the movement of the eye. It's not attached to anything, and so that slush, that blood is moving around in the eye. So that's all that gray material right there is vitreal hemorrhage. And then finally, lens dislocation, usually from trauma, and that's just where you have a lens in an inappropriate place. It's not right behind the pupil, right behind the iris. So here's just a still image of an iris, not an iris, a lens in an inappropriate position. Usually it's supposed to be right up here, but now it's just freely mobile, off to a side. It's no longer attached, no longer where it's supposed to be. So big takeaways today. You can't have too much jelly. Put a lot of jelly on that patient's eye. It'll make them feel more comfortable. It'll give you a better image as well. The findings that we looked at today was retinal attachment. Remember that one is the serpentine structure attached to the optic nerve, where posterior vitreal detachment is the same structure but not attached to the optic nerve. You also have vitreal hemorrhage, which has the washing machine sign, and then lens dislocation.